mitigate the impact of their own individual ACEs in their lifetime and to prevent those for their kiddos moving forward. So we're going to have presentations from both Julie and from Brenda today, and then talk a little bit about how we're going to move forward, the decision guide and companion guide. And, you know, from there, we'll go with questions and kick this project off. I do want to thank all of you for being willing to participate because we really needed to have a nice, you know, mixture of agencies and populations throughout the entire state. So let's go ahead and do introductions. For those of you who don't know me, I'm Joni Detwiler, and I am one of the consultants in the Maternal Infant Health Program. And Julie and Brenda, let's have you go next, and then we'll go to our participants.
Hi, everyone. I'm Julie Moore. I'm the one who has been sending you many, many emails over the last several weeks. And so really, really nice to see your faces, and so happy to have you all here. I'm a research scientist here at MPHI, and will be helping guide this project and have a real eye towards the data bits and the implementation pieces that we'll get to the end.
Thank you, Julie, and good morning. My name is Brenda Dietrich, and I also work at MPHI in the Center for Healthy Communities. And I'm super excited for this project because I have been working on the evaluation side and the quality improvement support side for home visiting programs in the state in other models. This is my first dive into MIHP, but when the CDC grant came through, the MIHP leadership was all on board because ACEs are something that is significantly impacting your population. So not addressing them is probably not the best course. So I'm excited to pilot this with you all. My background is in quality improvement and in evaluation. But it's also in ACEs for home visiting programs. I've had a few projects over the last 10 years around piloting different ACEs pieces with home visiting programs in other models in Michigan. So I bring some of that knowledge with me, as well as, you know, the emerging research that we have that I will talk a little bit more about today in terms of how we can prevent and how home visiting is a great spot in which to do this. With that, I'm gonna bounce it to Dawn because she's next on my screen.
Oh, excellent. And then if we could have folks just bounce to the next person afterwards, that would be phenomenal. You're on, Dawn.
Hi, good morning. I feel very lucky to be a part of this group. My name is Dawn Dotson. I'm a registered nurse home visitor for the Maternal Infant Health Program, full-time RN for nearly 40 years, but I really feel lucky that I participated back in the day, several years ago in Lansing, when our West Coast folks brought ACEs and Resilient Movie and Paper Tigers to Michigan for the identification and education regarding ACEs and its impact on all of us. So I really feel lucky that we're bringing this into MIHP and looking forward to the training and the work that we can all do to help our moms, dads, families, community, etc. So thank you. I think next, well, let's see. I don't know if I have a name. Maybe Marie Barks. I'm not sure if you're next. Sorry if I jumped a bit.
All good. Just popcorn to whoever you find next, and we'll get everybody covered.
Hello. Can you hear me?
Yes, we can, dear.
I'm Marie Barks. I am the coordinator for MIHP in Clinton County at Caring and Sharing Family Life Services. And I also have gone through, I am a community trainer for the ACEs and protective factors through the Child Abuse Prevention Council in Clinton County. And I will jump to Ray Ann.
Hello, I'm Brianne Olger. Hold on. Okay, maybe that made it better. Okay, I'm Brianne Olger, and I'm with Caring and Sharing Family Life Services here in Clinton County as well. I am a social worker, and I'm excited to check out this new pilot study. I am going to jump to Amy, is it Sizzler?
And yeah, Amy is Marie's daughter. So
Hi guys, I'm Amy Sisler. I work at American Indian Health and Family Services in Detroit, and I'm a social worker for the program. And Megan is next on my view.
Hi, I'm Megan Consul. I'm a nurse with with MIHP at Tuscola County Health Department. And then I guess we will jump to Christy Suber, who's my boss.
Right.
Hello, everybody. I'm Christy Suber. I am the coordinator here at the Tuscola County Health Department and currently filling in for the social work position. I was a home visitor for 20 some years, and so I'm kind of enjoying being back in this role. I have to say the first time I heard about ACEs was in 2004, right after my daughter was born. And I was at a conference. It was one of the statewide child abuse and neglect conferences. And it was sort of new to our area. And I remember there was like so many light bulb moments. And I'm amazed that 17 years later, we're still just like trying to figure out how to implement this into our families, because we know the impact that it has. So this is very exciting to be a part of this. So very cool. And I will pop it over to Sandra Gwynn.
Good morning, everyone.
Good morning.
I'm so glad to be here and a part of this program. My name is Sandra Gwynn, and I am the program coordinator for the MOST MIHP. And glad to hear more. I'm just excited to be a part of this program and hear more about it. Actually, one of my social workers brought the idea to me of becoming a part of the pilot program. So I'm so glad she's with us as well. And with that, I will just go over to AJ, who will be helping us with this project.
Hi, good morning. I'm AJ, a social worker, and I was invited by Sandra to help her with this project. And it's truly an honor to be working with MIHP, which has always been my passion. It's in alignment with my my personal and my professional mission. And so I'm just here to get information so that I can help Sandra really take advantage of this opportunity that's going to impact so many families. So thank you for having me, and thank you for inviting me, Sandra.
You're welcome.
Oops, sorry. AJ, if you could pop us to someone else, choose somebody on your screen. Oops, you're on mute.
Hello. Has Christy Super gone yet?
She has.
Okay, let me scroll down. Kyra Ben.
Okay, yes, that was right. So my name is Kyra Ben. I just started as a research assistant with Michigan Public Health Institute for the Center for Healthy Communities. So I'm very excited to be working on this project alongside Julie and Brenda. So I'm excited to see you guys' faces. I've heard a lot about the project, so I'm glad to really get it into action today. I'll say popcorn. I see N. Ross.
Hi, this is Cindy Kaff. I'm the coordinator of the St. Clair County Health Department, MIHP, and our whole team is on. They don't have camera, nor do they have mic, but they can see and hear, and we can communicate through the chat.
Perfect. All right, Marcie, you want to go?
Yes, good morning. My name is Marcie Montgomery. I am the MIHP supervisor for the Grand Traverse County Health Department. My team will also be participating. They are not able to participate today, but they are going to be in the pilot, and we are very excited to bring in the ACEs training into the MIHP services we provide, because I think it is so vastly important. Okay, let's see here. Karen Saul.
Good morning. My name is Karen Saul, and I'm the MIHP coordinator at the Kent County Health Department. And like other people, when I first heard about ACEs, mind blowing, and I thought, okay, what next? So I'm so excited the what next is finally here. And next on my screen, I will turn it over to one of Kent County's social workers, Erin Weeks.
Hi, I'm Erin. I'm one of the social workers for the Kent County Health Department. And I am going to hand it over to Katrina.
Oh, my name's Katie or Katrina. I'm a social worker at Kent County's Maternal Infant Health Program as well. I will pass it on to Whitney Ermatinger.
Hello, I'm Whitney. I'm a social worker with the Kent County Health Department as well.
Welcome.
I'm not sure who hasn't gone yet. Let's see. I'll send it over to Erica from our team, Erica Wamser.
Hello, my name is Erica. I am one of the nurses with the Kent County Health Department as well. And I believe Madeline on here is one of our nurses as well. So I'll pass it over to her.
Excellent.
Hello, everyone. My name is Madeline, and I've been a nurse in MIHP for 3.5 years, and I'm very excited about this pilot. And I will hand it over to Laura.
Hello, my name is Laura. I'm a nurse with the Kent County Health Department too. I've been there for about a year, and I'm curious to learn more today. And I will pass it to Renee Dunwell.
I apologize, my camera is not working. My name is Renee Dunwell. I am the other MIHP supervisor at Kent County Health Department. And let's see.
It's always harder at the end to know who to go to.
I know, it's like the memory game. Let's see. I will pass it to Kaylee.
Hi, my name is Kaylee. I'm a social worker at the health department in Kent County. I've been there for 2 years and I got kicked off, so I'm not sure who still needs to go.
Yeah, we can have anyone who hasn't gone yet, go ahead and jump in.
Joni, this is Maria. I'll go ahead and jump in.
Thank you, Maria.
Yeah, of course. My name is Maria Elrez de Lopez. I'm the MIHP supervisor at Ottawa County. I've been in the home visiting space for about 35 years. That tells my age. First as a MIHP participant, and then as a CHW, and now as a supervisor. So I'm super thrilled to be part of this project and incredibly grateful that we were chosen.
Excellent.
I will pass it off to Cynthia.
Hi, I'm Cynthia. I'm a part of Ottawa County's MIHP. And when I first started in the late 90s, we were starting to talk about ACEs in the infant mental health space. So, excuse me, it's nice to see how it's evolved and it's going to become a part of MIHP. And yeah, I don't know who else needs to go. So whoever needs to go ahead.
Jump on, I haven't gone yet. My name is Sarah Engstrom, and I am the program coordinator for Marquette County, way up in the UP.
And how is your weather up there, Sarah?
It's pretty fair for right now, honestly.
Excellent. All right, if someone else can jump in. We've got the folks from St. Clair County putting their introductions into the chat. All righty. Let's go ahead then. If we don't have anyone else who's going to introduce right now, we'll turn it back over to Brenda and Julie to go through our presentation. And as I said, if you have questions along the way, you can put them in the chat or hold on until we get to a break in the conversation.
Thank you, Joni. And I am going to kick it off with a little bit of background around ACEs and positive childhood experiences and protective factors. how home visiting fits into this piece of the pie, and then start the conversation around the ACEs Prevention Plan of Cares, Maternal and Infant, and the companion guide that goes with it, before I hand off to Julie and Joni to talk about how it will be implemented and the decision guide that goes along with that. So first, we'll take a brief look back at where science has been on adverse childhood experiences, how they're likely impacting the families you support every single day. I realize many of you have received some level of information via your introductions or just what Joni has shared with MIHP offering training back in 2014. It's been some time since the original study way back in the 90s on ACEs. However, as Christy said, we're learning as we go along. There's new information coming out. And we're just going to refresh for a moment to ground ourselves in what the original ACEs were, and then turn to that newer information and newer science around positive childhood experiences and how home visiting fits in cultivating those PCEs and protective factors in families. And I would like to say we're very interactive in our training. So if you have questions, feel free to pop them in the chat. Julie's going to be watching it for me to make sure that we stop and we explain anything that you have questions about. So just some brief information, you know, ACEs stands for Adverse Childhood Experiences, things that happen in our childhood, physical and emotional abuse, neglect, mental illness in the home, household violence, things like that. And it's been demonstrated over and over that the more ACEs that you have, the more likely you are to suffer from other negative long-term conditions. So the main 10 ACEs here in the graphic, under abuse, the physical, emotional, sexual; under neglect, physical and emotional; household dysfunction, mental illness; incarcerated relatives, substance abuse; IPV in the home, divorce. Those were all things that were identified in the original study, but we know since then that there are other factors that also qualify as ACEs, such as historical trauma against Indigenous populations or generalized racism in our country, poverty, housing instability, war, natural disasters, and other mass impact events, we know have the same sort of long-term effect and are being brought under that ACEs umbrella. Some of these are on the community or country level, and then we have global ones. I know the most recent mass impact event for all of us is the pandemic that has had significant effects on children and families. And the context of how these past 2 years are going to continue to have ripple effects is part of that mass impact ACE. The original ACE study moved that lens from asking what's wrong with you when you encounter people who are just not making great decisions or have poor health, you know, asking what's wrong with someone used to be the mode that people took. When ACEs came out, that lens switched to what happened to you. So what happened long ago that was predictive of these negative outcomes that you have later in life? Adverse childhood experiences have been shown to have those long-term impacts across a lifespan. Injuries, mental health, maternal health, infectious diseases, risky behaviors, and limiting life opportunities. Within your MIHP population, and in the greater population served by other home visiting models in Michigan, the rates of some of those ACEs are much higher than that original study. The original study was very much on a white middle-class California population. We found the rates to be higher when we do screenings across the MDHHS-funded HFA programs and NFP programs. We see much higher rates, even within those models, for things that would be ACEs. Home visiting has historically targeted families who were termed higher need or high risk, which is not very strength-based. Those families on average, again, have higher rates of substance misuse, mental health challenges, and lower levels of educational attainment. What is new and important for those in the field serving families who are impacted by ACEs is emerging science on how protective childhood experiences and a two-generational approach, which we'll talk about in a little bit, is helpful What is clear is ACEs have lasting impacts that show up in our behavior and choices as adults and parents, but there is a huge, huge space here to make changes to turn the tide on this. What is also known as ACEs are incredibly common. 67% of the population from the original ACE study had at least one. And we know that significant kind of soundbite from the ACE study of those who had more than 6 ACEs could have a reduced life expectancy by as much as 20 years. That one has always stuck with me. It's a huge impact. Again, that population was largely middle class and white, so statistics across other groups and groups within Michigan can be much higher. The Medicaid eligible population in general, we know has higher risk factors, which is one of the reasons that led to the creation of MIHP. The higher rates of ACEs in the proportion of caregivers, we just expect it to be higher. It hasn't been analyzed, but it would make sense. ACEs are very common. 1 in 6 adults experience 4 or more types of ACEs, which is a lot. And the top of the top 10 leading causes of death, 5 are associated directly with ACEs. So there's emerging research that preventing ACEs could reduce the number of adults with depression, for example, by as much as 44%. Preventing ACEs can help children and adults thrive and potentially lower the risk for conditions that you see every day in your work, with depression and diabetes and just struggles with health and well-being, as well as risky behaviors. ACEs are also frequently co-occurring, which I'm sure you've seen in your practice as well. If one ACE is present, there is an 87% chance that another is present, and a 50% chance that there's 3 or more. Caregivers and MIHP are likely being impacted daily by multiple ACEs. Along with being common and having high rates of co-occurrence, ACEs, again, are found to have a graduated impact. So the more ACEs you have experienced, the more likely you are to have those negative impacts on behaviors and life potential. Some are weighted more than others, having greater impact, but overall that dose effect has been very much demonstrated. So in looking at ACE impacts for families, in MIHP, as you support families during pregnancy and infancy and toddlerhood, your littlest beneficiaries are possibly already experiencing ACEs in the environment. They're being born into, and brain development is so rapid at this stage that impacts can be significant. So it's a critical time to intervene upstream in their lives to reduce ACEs in the environment. At the same time, though, you're supporting caregivers who may be exhibiting the results of their own ACE experience. MIHP is a significant support to families during this time of prenatal to toddlerhood, and the positive supports you bring are so critical to families with current or past ACEs. ACEs can also be intergenerational, which again, Joni shared a very poignant story about one family that she served with us long ago who had an intergenerational transfer of ACEs that was just heartbreaking. But we know this to be the case. You know, you learn your patterns from your parents, you learn from the way that you were raised, you learn and are molded by those ACEs that you have in your childhood. A big part of that intergenerational transfer is also in the continued impact of stress on developing brains. Some stresses make us more resilient and healthy. Those are more on the positive and tolerable end. Where we run into some challenges is toxic stress, which is lasting stress without the context of a supportive environment. And that can modify a child's stress response for life and lead to poor decision-making later. A key is in the balance here of adverse and positive experiences and supports, which home visiting in MIHP is a key part. So diving into more recently, protective factors have been around for a while, identified originally in the child welfare field, and then migrating out into other home visiting programs. And the Positive Childhood Experiences Study, which is very much more recent. It was published in 2019. They've both shed light on how direct supports and positive experiences in childhood also have impacts and can significantly reduce the impact of ACEs on a person's life. You can argue the field of home visiting has been doing this all along, providing supports to families to address a risk. This approach has largely been deficit-based, with a movement more towards strength-based approaches in the recent decade. So more talk about resilience and those strengths that families have already. Even within the ACE field, as the focus has shifted to understand how negative experiences early in life are associated with negative outcomes in adulthood, an approach that can leave those who take an ACEs history screener to feel, now what? They can't change their past. There's now been a shift to where in the stream of life differences can be made. How are some people able to build resilience out of adversity and others are not? How can communities and programs turn the tide on ACEs using that knowledge? That place for early service programs like MIHP is in building protective factors and nurturing the foundation for families to build positive childhood experiences. So protective factors, again, are likely familiar to you. They've become common not only in child welfare, but across home visiting. And I'm sure if you've seen presentations from your CAN councils, it is something that they very much educate on as well. At least the first 5. More recently, parental resilience was added to the initial 5. So nurturing an attachment, healthy parent-child relationships, having children receive the love and respect that they need every day, knowledge of parenting and child development, families knowing and understanding that part of being a great parent is natural instinct, but part of it can be learned. And this is one of those spaces where ACEs may be framing the way that they approach parenting right now, but reframing in a way that recognizes and honors that no parent sets out to be bad at parenting. Children don't come with manuals, and we come preloaded with our own experiences from ACEs and positive childhood experiences. So sharing information that helps reframe or break those intergenerational ways of parenting and disciplining are very important here. Parental resilience is the newer one. Families who are strong and flexible are better able to deal with the many stresses of everyday parenting in life. Social connections, having a network of trusted people. We all need friends, especially when you're parenting. Concrete supports, meeting basic needs, housing, transportation, healthcare, mental health services, and then social and emotional competence of children. So families teaching skills that assist children in communicating their feelings, solving problems, interacting in a positive manner. This is highly reflective of your work on attachment and parent-child interactions. The very newest piece is the highlight on positive childhood experiences. So the positive childhood experiences study was by Christina Bethel and Bob Segi and others back in 2019, and they wanted to begin to understand what made the difference between people who experience an ACE and go on to have negative outcomes and those who experience the same ACE but did not have as significant of an impact from that ACE or any impact. What they found was that the difference was in the number of positive childhood experiences a person also experienced during their childhood. So it's a bit of a teeter-totter balance between the positive and the adverse childhood experiences. And they came up with 7 that they could categorize those experiences into. So that that person felt that they were able to talk to their family about feelings, that their family stood by them during difficult times, that they enjoyed participating in community traditions and events, that they felt a sense of belonging in high school. They felt supported by friends. They had at least 2 non-parent adults who took a genuine interest in them, and that they felt safe and protected by an adult in their home. While initially it may seem that home visiting is hitting a bit too early to impact half of these, 6 and 7 are more directly where families might be at right now. Having support though when families are laying the foundation for their parenting and what their family will have ripple effects later. It's kind of a challenge to our psyche that we often do not see or know the impacts of early childhood services or the impact that you as an individual home visitor or nurse home visitor or social worker have on a caregiver or a child's life. But the research is out there to underscore that supports like home visiting are the building blocks for creating an environment in which positive childhood experiences can thrive. The impacts of those positive childhood experiences in balancing out the negative impacts that ACEs can have was part of what Bethel and her colleagues found in their study. Their study focused primarily on mental health impacts, and what they found was 3 to 5 PCEs correlated to a 50% lower risk of poor mental and relational health in adulthood. And having 6 to 7 resulted in a 72% lower rate, which is a huge impact for building those pieces early in life and having those supports when they were younger. So home visiting and MIHP, I've kind of woven it throughout, but I want to call out specifically how home visiting and MIHP is a key partner in preventing and reducing ACEs. So again, I've talked a little already about how home visiting is providing those supports and foundational pieces for families that can balance ACEs with protective factors and positive childhood experiences. Narrowing down to individual home visiting programs, what do you do currently? What can you do? You provide those supports and services in home to families when their children's brains are in their most critical development stage. And the impacts of those adverse and positive experiences are magnified. You're laying that groundwork in providing holistic supports to both the caregivers and the children in the home. So it's a 2-generational in-home approach that has been shown to be effective in reducing those long-term outcomes. Home visiting services overall have demonstrated reductions in child maltreatment, increases in school readiness, and benefits to maternal and child health and other positive outcomes. And viewed through the lens of ACEs and positive childhood experiences, there's really a huge opportunity here to, one, understand why families struggle because of their past experiences, but also to think about how to reframe and how to support parents in creating a childhood that was maybe different from their own. So ACE prevention, within home visiting specific to ACEs, we think of the 3-prong approach for ACEs mitigation and prevention. The CDC recognizes and lists home visiting specifically as a proven key partner for ACE prevention and ensuring a strong start for children. MIHP and other home visiting programs provide supports that again balance those out. So you're building resiliency through protective factors, you're supporting attachment and other positive childhood experiences, and you're through your supports and supporting parents to get treatment or learn different techniques for parenting, you're reducing that ACE exposure and the intergenerational transfer through those service connections and supports. The CDC, again, specifically lists it as a prevention strategy in ensuring a strong start for children. Looking at ACEs data and the negative long-term impacts of having experienced ACEs can feel disheartening as home visiting providers. Past projects that I've had with ACEs that did implement an ACE screening, it can highlight how focusing on an ACE score is sometimes not as helpful, as it can feel a bit like what's done is done, and having that conversation and digging into, getting that score of ACE history for caregivers can feel like you're opening just a box of things that then it's a struggle to figure out how we can move forward together. There's a lot of opportunity, however, to shift the impact of those ACEs already experienced or currently being experienced, as well as build that foundation again for positive experiences. If you saw you attended the home visiting conference this year, Bob Segi actually was a speaker at the conference, and he talked about the HOPE project that he has through Tufts University with healthy outcomes from positive experiences that brings in the protective factors and the positive childhood experiences, focusing not on ACEs specifically, but instead on building the resilience and positive aspects is a natural fit with home visiting. It's in part what, again, you've been doing for decades. It's just putting a structured framework around that. And again, it's that graphic of balancing it out, right? So you've got MIHP programs are supporting building those positive childhood experiences, protective factors, and overall family resilience that will hopefully reduce the impact of adverse experiences and negative stressors in the home at a time when the child's brain is developing so rapidly. So in addition to, setting the stage for positive experiences, working with families on protective factors and building resiliency, MIHP also, you connect families to needed supports that help for creating an environment in which the impacts of ACEs experienced by caregivers is lessened and the family develops and nurtures healthier paths to prevent ACEs for the infant and other children in the home. This is especially important, I think, right now as the collective cultural impacts of the pandemic on families are felt, and emerging data are underscoring that those impacts are being felt inequitably, and those already experiencing stressors are far more likely to have suffered and continue to suffer. The need is great to focus on resiliency building and positive experiences as tools to help families build those foundations with their infants that chart a healthier course in the event of huge stressors. I have a few data slides just on the impact that can happen on those long-term pieces in ACEs when you have supports like home visiting and having someone in your life who helps you connect services, supports you in your goals around that. So for those who have a significant amount of ACEs, the percent of the population that reports feeling depressed all or most of the last month, you'll see drop significantly to from 12% to down around 2% for those who had support. We see similar things across poor mental health, lasting more than half the last month. You have drops from nearly 40% to looking to just under 10% for those with the most ACEs. And there are impacts for the other groups who have lesser ACEs as well. But I think it's incredibly encouraging to see how much of an impact support can have. This one is on poor physical health. It's the same sort of huge drop that you see when a family is supported or a caregiver is supported. And the last one is smoking support. So I know that this is a tough one across our home visiting programs, but it too, with high support and hope, will and can drop significantly. So that was kind of a quick tour through that. I will say in the companion guide, there are links to additional trainings that dive into ACEs, that dive into HOPE. There are some tribal resources and a tribal training around ACEs in the community for the tribal population. When we were exploring, trying to find a training, there really wasn't one that brought in ACEs, positive childhood experiences, and what this means for the home visiting program. So I hope that it was helpful to just run through that a little bit before we turn to the prevention plan of care and the companion guide that goes along with it. So the ACEs prevention plan of care, part 2, and the companion guide, it uses strategies on multiple levels. So support for healthy parent-child interactions, to reduce the likelihood of ACEs and increase those PCEs, mitigate the impacts of currently experienced ACEs in the home, and mitigate the impacts of caregiver experienced ACEs. So you're working on multiple levels every day. The strategies include handouts for caregivers on ACEs, resiliency, positive parenting practices. The companion guide has prompts for discussion with caregivers on the impacts of current historical ACEs. And there are prompts for providing resources to parents to explore themselves. Additional resources are in the companion guide, which I'll walk through in just a little bit. To help with that. So there's two pieces here. There's a maternal ACEs prevention plan of care. There's an infant ACEs prevention plan of care. They both have the same strategies on them. But Joni and Cherie agreed that there should be one for each of those buckets. Then we created a companion guide to go alongside this to help with prompts for different conversations and to include a bunch of resources that you can use as you go along. I will note for the ACEs prevention plan of care and the companion guide, at this time, there is no ACEs history screener requirement. This, Julie will explain more in a little bit how the calculations are made for the algorithm. However, it was deemed it was too much to add one at this time, and it is a very deficit-based approach to do an ACE screener without balancing it out with resilient screener or positive childhood experience screener as well. So we really tried to build this within what you already have in place, because you do have quite a few things that are collected on the MRI and the IRI that are related to ACEs and could give enough of a sense of when this plan of care could be most appropriate. So there's no ACE history screener requirement. There's also no positive childhood experience or resilience screener, which is a bit of a missing element when we're looking to identify strengths within the families. It's currently, again, grounded in the existing MRI and IRI. So it is very much related to existing plans of care, the abuse and violence, alcohol, housing, family and social support, stress, depression, and drug use. You will see on Julie's sheet. I will make a note that poverty was not included. It applies to everyone in the MIHP bucket, as you know, Medicaid eligibility being a requirement to receive the service. And we discussed at length, whether or not that should be one of the factors, but we, in the end, chose not to. ACEs is a lens for why other plans of care may be difficult for families to make progress in. So we're hoping that having this companion plan of care will help. For those families with more than one plan of care, we would strongly encourage you to consider the ACE prevention plan of care part 2 to be a priority, because it can help the family reframe why these other pieces are a challenge or happening and put a little bit more of a positive spin on it. So this is just a little shot of the infant and the maternal. Again, the strategies are the same. The only change came in who it's directed at, but you will see one for each of the buckets. And if we look a little bit bigger here, Julie is going to talk about the left column in a little bit and how the scoring and decision making works. I'm going to walk through the different strategies. So as with any other plan of care, it's kind of a menu piece, right? So you pick up the pieces that would be most beneficial to the family that you're serving from your professional vantage point. I started at the top with just an overall one to discuss ACEs and positive childhood experiences, letting parents know that it is prevalent and that it can have impact. I mean, it's very common, but it can impact. Talking about ACEs that are also in the environment for the infant and other children in the home, and the role of the PCEs and protective factors. And then, as always, you're going to want to make referrals to appropriate mental health treatment provider, infant mental health service provider, or community resources for support when it's appropriate for the family. When we get to the companion guide, you'll see that there's also sections for each of these intervention strategies. So for 1 through 5, there are specific pages for them. 6, 7, and 8 are all on one page, and we'll visit that in a second. The second one is to review and discuss ACEs and parenting to prevent and heal ACEs handout with the beneficiary. So this is one of the cases in which we put in a specific handout. For some of the other interventions, you'll see multiple handouts suggested. You can also bring in other handouts that you have. As Julie, I'm sure we'll talk about in a little bit, this is a pilot, so we are trying this out and we are very open to your feedback on if there's a better handout out there, if there's a better handout for a specific population that we did not include. Those are things that we want to know. If some of these handouts and pieces don't land well, that's something that we want to know as well, and we'll be learning together over the next several months as we pilot how this goes, how it's received by families, how it works for you when you're providing services. The third one is about reviewing and discussing the 4 building blocks of hope with the beneficiary. So the pieces from Tufts University about how to build hope early on in childhood. The fourth was discussing protective factors and the reduction of ACE impact for children, utilizing 1 or more of the approved tools in the companion guide. So for this one, there's multiple tools. And if you've ever been to the Protective Factors Toolkit site, they have many, many handouts. So we culled out, a few that are very appropriate to this particular lens. There's a question, are these available electronically or have QR codes? They are included in the companion guide, but there's also a link to where they are electronically within the companion guide. We did not have QR codes for them. So good question, Maria, but you will have print copies of them electronically sent to you in this big companion guide, but that companion guide also again includes the links to the source of all of those handouts. So if you prefer to download it yourself or explore that site a little bit more, you are welcome to do so. The fourth one is discuss protective factors and reduction of ACE impact for children utilizing 1 or more of those approved tools. 5 is stress reduction and self-care strategies, which are so important for managing the impacts of ACEs for your caregiver, as well as setting a healthy stage for the infant in the home. And then 6, 7, and 8 are related to specific ACE factors that have strong correlations. So substance misuse, mental health, interpersonal violence. And then 9 is discussing additional ACE factors. So again, as I said much earlier, since that first study identified the core 10, there are other ones that have been shown to correlate as well. So family member incarcerated, their own history of physical or emotional neglect, environmental substance exposures, racism or historical trauma, death of caregiver, living with a family member who has mental illness, and mass impact events are all things that we put into that bucket of additional factors. Moving on to the companion guide. The companion guide is set up to provide a little bit of guidance overall for the interventions themselves, and then also provides you a whole bucket of resources that you can access. What I'm going to do is stop sharing the slideshow and switch to sharing the companion guide itself. So the companion guide itself is laid out with first an introduction page that includes the protective factors and the positive childhood experiences. And then it walks through those interventions. So the first one was about talking about ACEs with caregivers. And there's a related attachment, attachment B, that, oh, it says my screen sharing is paused. Can you still see it? Yeah, I see Marianne.
Brenda, we're looking at attachment A, additional resources. ACEs 101, hope, and preventing adverse childhood experiences is what we see right now.
Okay, so it froze. Okay, let's try again. Okay, does it now show talking about ACEs with caregivers?
Yep.
Okay. Okay. So here we've pulled out a few prompts, and I will say that there are two toolkits out there. The Near at Home you've probably heard about. It was designed to bead intervention around ACEs in the home visiting setting. It is designed, however, to be based around doing an ACE history screener. So we did pull some of the prompts out of the Near at Home toolkit, and there's a link in this companion guide if you would like to go see the Near at Home toolkit yourself and look through it. But that guide is very much directed at if you're doing an ACE history screener and then talking through that with the family. So we adapted some of those guidance statements and prompts for how to start these conversations. But again, the Near at Home is based on doing a history screener, and it also came out before all of the literature around positive childhood experiences. So it includes a little bit around resilience, but not as much around building hope and positive childhood experiences and protective factors as I would like. But it is a good toolkit for just getting some guidance around how to talk with families or what minefields might be there. So talking about ACEs with caregivers, ACEs and parenting, and each of these has a reference to an attachment. So if we skip to the resources, the first attachment again is pieces around training. There's a couple resources for parents. There is a toolkit, the 123 Trauma Sensitive Toolkit for Caregivers of Children that was developed by some nurses out in Spokane. That does address trauma, but again, it's another one of those resources that came out before the positive childhood experiences, more recent information. But that toolkit was developed to use with caregivers. So it has handouts for them, little projects to do with their children and things like that. There are some overall resources for programs and then a few tribal resources. With the attachments for the specific interventions, attachment B is an example here. So the Understanding ACEs, you have the link to where it came from so that you can download it yourself if you would like, or we have also embedded the versions that were available here within the guide. So just trying to make it easier for you, put it all in one place, but I do understand if you want to go download it yourself or it doesn't come across quality-wise here. So for each of the attachments, that is the pattern that it follows. Are there, I know I kind of whizzed through that, but are there any questions at this point? Oh, Julie was telling me to zoom in. I'm so sorry.
You're good. And I did mention in the chat that everyone did get an attachment to that companion guide as a PDF if you want, with the link to this meeting. So feel free to look through it on your own.
Mm-hmm. And again, with the interventions, some of them specifically ask that you do use the particular handout that's there, and the others are a bit more flexible. If you have something that is more pertinent to your population, again, that's okay. We ask that you share it back with us though and let us know so that we know how this is working, how you're using these pieces or not using these pieces, because we want this to work for you. Because if you don't have good support and good materials, in turn, the family won't have that good support and materials.
And I wanted to support that as well, because I think one of the things that's so exciting for me about this project is that we've got all of us coming together to give feedback about whether or not the handouts are working, what would work better? Are there things that we can link people to that will help them have that aha moment and really be engaged in working to reduce ACEs and preventing those for their kiddos? So yes, that's one of the exciting parts about this entire pilot.
Very much so. And I think we have a 15-minute break built in. Okay. So we're just going to take a 15-minute break, come back at 1/4 after, and then Julie and Joni will go through exactly the decision tree for using the plan of care, and then how the pilot study will work. Okay, so we'll be back at 12:15.
And get started, or?
Sure, that would be great.
And maybe we'll take 1 minute to start the recording up again.
All right. Well, thank you everyone for coming back from break. As we talked about a little earlier, one of the things that is very exciting about this process, and we were just mentioning, is the fact that we're going to be learning together. So we want to make sure that, even though there's a lot going on in MIHP right now, we've got new cycle 9 rolling out, we've got our other pilot projects going on. This is going to be a long-term plan of care that'll be utilized throughout the state. So you really are incredibly important right now in giving feedback about anything that you either find really exciting, irritating, too much work. There's going to be some recording that needs to be done. And as you're doing that, it's going to be really important to give us feedback so that we can make adjustments to make this plan of care implementation as successful as possible. So as we're going through this last section here, we're going to talk about the actual implementation of the plan of care and then some of the recording mechanisms. Some of you have EMRs, some have paper charts. So we're going to try to make it as easy for you as possible. But also, again, thank you so much in advance for critical feedback, whether things are good, bad, or ugly as we move along. So Julie, I'm going to go ahead and turn back over to you.
All right. Thank you so much for that, Joni. So for this section of our training, we're going to focus on some of these implementation pieces for the pilot itself. So we're going to be talking about the decision guide, a guide that is going to help us with the algorithm to help you figure out which families are most recommended to use the new ACEs Prevention Plan of Care 2. We're going to talk about some strategies for internal tracking for keeping track of both the families who are screened and recommended and those you actually deliver the plan of care and have these conversations about ACEs with. We'll talk about our monthly TA calls, which hopefully those appointments are all on your calendars, and we're excited and ready to go with those. But we'll talk a little bit about what we'll do on those calls and the purpose of those calls. And finally, we'll talk about that monthly data reporting just to keep track of and understand how things are going with you and your families. Okay, so this decision guide for the ACEs Prevention Plan of Care 2 is another one of the PDF attachments that was sent to you along with this meeting link. So I've got screenshots here to follow along. Feel free to pull up the actual PDF if that's easier for you to look at it and as well. So as Brenda introduced in her section, we are trying to use the materials and familiar screeners that you already have through MIHP, given that we don't have an ACEs and PCEs specific screener to introduce at this point. So our two largest data sources for understanding whether a family is at particularly high risk for ACEs. The first one is our risk identifiers. So depending on whether the mother is the beneficiary or the infant is the beneficiary, you would use either the maternal or the infant risk identifier. And these are the domains that that other algorithms are already scoring for moderate or high risk on those identifiers. So for our purposes, we're going to take a really high level look at those and say that if a mother or family is coming in at moderate or high risk for these domains on the risk identifier, we're going to consider them at different risk levels for ACEs as well. So for example, if we have a parent who, or we have a family who came in at moderate or high risk for the housing domain at one of the identifiers, and stress and depression, we would mark that here on our worksheet. And for our risk identifier level, we'd have a total of 2 identified from the risk identifiers. As Brenda also mentioned, we know that the risk the ACEs adjacent and ACEs themselves that are currently present on the risk identifiers aren't the only ones. And so we have a place here in orange for some of those other risk factors that may emerge organically as you're getting to know a family through visits and you're having conversations with them. Some of these other ACE risk factors may come up and emerge. So here's a section for you to track and note that as well. We want to really, as Brenda mentioned in the last section, we don't have, this is not a formal ACE screener. So we really want to, these aren't things that you have to ask families about, and we're not encouraging necessarily to go through this list to ask and talk with families about. These are more things that may come up organically as you're getting to know the families, and if they do and they're applicable to our work here, then please do note them. So in our example here, we might have a family who may share that they have experiences with racism or historical trauma, and have either a current or a past experience living with a family member with mental illness. And so they would have a total of 2 for this bucket. And then we kind of add up both of these sections to get all known ACEs risks on our screener here. I also wanted, again, Brenda also mentioned this, and I want to reiterate it here, that this is, of course, we're talking about multiple generations of ACEs risk. So many of these domains that come from the risk identifier are pertinent to what's happening with a parent, and might even be in the parent's past or in their current experience. So we understand that this might feel like a mix of ACE risk that might be happening currently right now for that baby and other children in the home, and a history of ACEs that a parent might be experiencing that they're carrying with them, but might not be ongoing currently. So we understand that it might be sort of a blend of those 2 types of risk coming in. I'm going to pause here before I get to the second page and just see if anybody has thoughts or reactions or questions to the algorithm or the decision guide so far.
As far as the decision guide goes, if you have additions, say over 4 different home visits or something, you know, maybe you add a POC later on, is there a way that you're intending us to designate when they were added?
Good question.
Yeah, that's an excellent question, and it's one that that I'm going to part answer and part dodge as part of the pilot. The answer to that is we totally expect that some of these things are going to be emergent through the course of your various home visits. So absolutely, yes, as you are building a picture of the family that you're working with, we want you to keep building this profile with them as well. So yes, you can keep noting that up in any way you can. We're going to talk in a minute. This PDF is one way to think about the flow and to take notes and keep notes on the family. We're going to talk in a little bit about other ways that you can kind of keep track of some of those changes and that status changes that might be happening. And that a status change, like, oh, when we first, met with this family, they came in at lower risk, and now more things have emerged and we realize they're higher risk than we realized. And so we are prepared for that reality, and we have a couple of mechanisms built in to handle it. And that's one of the things we actually need to hear your feedback on through this pilot period to understand what that looks and feels like for you, and what we would need to do to make tracking that a little easier.
So this decision guide can be used both for currently enrolled clients and new enrollees into the program.
Correct. So that would be part of how we're going to be learning which families we want to use the plan of care with. So the risk identifier information will be pretty easy to put in there, but then as you move along, you may see other factors that come into play. Any families that are enrolled in your MIHP will be eligible for this.
Great questions. Anything else before I scooch on to that next page?
Yes, Julie, this is Sandra.
Hey, Sandra.
Is there a number you have in mind for the amount of families we're to use, or is that our decision?
Yeah, that's a great question. Let me keep going in the presentation, Sandra, and maybe that'll get answered in a minute, okay?
Thank you. Kind of
yeah. No, that's great. That's great. Okay. I'll go ahead and go on to the next page then. So this is the second page of the decision guide, and where you will bring your totals down from the first page. And we have different cutoffs for depending on kind of where the ACE risks are coming from. So in our example here, our risk identifier total came in at 2, and that puts this family, if that was the only information we had, that we would consider them a moderate risk for ACEs. We know, though, from our conversations with them through our home visits, that we identified another 2 risk factors that we're concerned about. So alone, that would again leave us at a moderate risk. But when we combine them for that 4, that does put us into that higher risk category. When we're making decisions about thinking about who we're actually going to deliver the ACEs plan of care with, we'd like you to think about the highest ACEs risk category from any of these lines above. So in our example here, since our total kind of bumps us up into that high risk bar, we're going to think about this ACEs plan of care as required for this family, and thinking about that this family would really strongly benefit from the ACEs discussion that Brenda outlined, along with the different resources. And Sandra, I haven't lost your question. So thinking about total number of families, I don't think we know that right now. And I think that's part of the information we're trying to get from the pilot and with your all's experience. We are actually very curious to see and understand if this algorithm ends up bringing in the vast majority of your families into either the strongly encouraged or required space for the ACEs plan of care, or if it's just selecting a smaller subset of families. That's actually one of the things we were really hoping to learn during the pilot. And I'm seeing Joni and Brenda nod, so I think we're on the same page there. So we don't want you to think about having to kind of come into a particular number of families. We want you to think about it as being a good fit for the families based on all of the information that we have. Joni, do you have anything to add to that?
I do, and I think that one of the things that is a challenge when we look at this is that a lot of our families are going to have multiple ACEs, and we may not have the capacity to utilize this plan of care with everyone who falls within that strongly encouraged or required grouping. And I do want to let folks know with the required, there's nothing associated with certification with this pilot at all. The required is really, looking at if a family has 4 or more, we really should use this plan of care with them. But, that's part of what we're going to learn from you along the way is, do all of your families, fit into the algorithm and the criteria to use the plan of care? Or is it half of your folks? Do you have the capacity to provide those interventions for everyone within your caseload who does score in the strongly encouraged or required? So that's the piece I think that's going to be really helpful with utilization as we move forward, is seeing, what your experience is in the field. Because we can design all these wonderful tools and have great resources for you, but if it doesn't work with the families, then it's not something that we want to, impose on folks. Brenda, any comment from you, dear? Okay.
Great. Are there any other questions about the decision guide and how we can at least start using it as our baseline as we kind of are learning about implementation? Any other questions about it that we can address right now?
So would best practice be to just start with the families that we're just currently seeing and those that are enrolled, or to do almost a scan of our current caseload and start looking at doing some of these decision guides with some of our families that we know could fall in to start implementing this? Or do you organically just want it to start as we start moving along, or should we be doing any review? Does that make sense?
Joni, I'm going to let you respond to that question if that's good.
Yeah. And, a lot of times when we roll things out in MIHP, we ask you to utilize them with new people enrolling in the program. Because we know a lot of our currently enrolled families could benefit, we're going to leave that decision up to you regarding whether or not you want to do that scan, Christy, and see who might benefit now. It really does depend on your capacity as you're moving forward, because we don't want to overwhelm you in a time of great stress and increased workload with the decreasing resources. I guess I'd like to hear from other folk. Does it sound like it makes sense with, just utilizing this as new folks get enrolled, or really doing that scan that Christy was talking about of who you currently have on your caseload? Amy's saying she'd like to try with current families. That'd be great. Other thoughts?
Yes. Before I make a decision, I'd like to know what else is kind of going to go into this besides just doing the screener, because I would screen everybody, but I don't know what else we're doing along with this.
Okay, sounds good.
I don't know if I'm going to be overwhelmed.
Further. Yeah, and Cindy's saying anyone enrolled after January of 2022 or after. And I guess for Julie and Brenda, can we have just a mixture there of folks who are enrolling, just newly enrolled folks, folks who are doing a scan of current, and then gathering some of that information in our technical calls?
Yep. Yeah, I don't think we have, unless you have another idea, I don't think we had a strong, a strong recommendation for which families to roll out first with. And I think it really could be a hybrid approach, Joni, as you were, saying, based on different sites, bandwidth and comfort level. And it may change quickly as you're getting to know the plans, the plan of care too, and the companion guide. As your comfort levels grow with it, you may think very quick, oh, maybe we can screen some of our current families, or move forward with some other families now that we're getting a little bit more comfortable with. So I think that is somewhat of a personal decision from site to site, and we would love to hear kind of how you're making that decision, how it's going for you in those TA calls.
And that will assist with rolling out statewide. Because when we look at capacity throughout the state, we do not want to overwhelm folks with adding this new component. We want this to be value added and linking those other plans of care. And yes, you could still utilize the tools with your current clients, even if you're not going through this decision tree process.
I think, the core here is we're trying to get information about how it works in different scenarios. So the hybrid approach is great because we can then, as long as we know what each of the programs is doing, it will help us understand, okay, for programs who are just starting with newly enrolled clients, does it take a long time for trust to build and for those scores to accumulate to a point where it would recommend it? And what does that capacity piece look like? As Joni mentioned, if it's going to be rolled out system-wide, what should be the framing around that? Is it overwhelming to look at your entire caseload and think about it? And then the third piece is learning if you're going to use some of these pieces with other families in your program, even irrespective of screening them for the particular plan of care. I would want to really know from you how the families received it and, how the home visitors felt in those conversations. Were there any challenges? Because that's overall information that's going to apply to any family that you're using these pieces with. That would help us learn which handouts maybe are helpful and which are not so well received, either at, the home visitor and staff level or at the parent level and in the family. I think we're just eager for information.
Yeah, and that's part of why we chose agencies that have very small caseloads and very large caseloads, agencies from urban centers and rural areas, because there may be some factors associated with, your part of the state or how many, beneficiaries you're actually serving that inform that process for moving forward on a statewide implementation.
All right, great. I'm going to keep moving forward in the interest of time, but do keep peppering those questions in the chat or coming on in with them. So the next piece is about the internal tracking for the ACEs prevention plan of care. So there are, as we've sort of alluded to already, there are 3 big pieces of information that we're hoping to keep track of during this pilot period. One, which families, how many families and which families you actually were able to screen using that decision guide. Which families actually received the ACEs prevention plan of care too, and companion resources. And 3, just those notes, those observational notes that Brenda just described about how things, and Joni talked about how things are going for you in your site, with your families, with your home visitors. These first 2 pieces about just the numbers of families screened and sort of where, what their level of risk is for the ACEs plan of care and how many families have actually received some aspect of an intervention, we'll be asking for in those monthly data reports. And we'll talk about those in a minute. Those will be aggregate numbers, so summaries across your whole site. And so not individual families, but just summaries of how many families have been screened and how many received the plan of care cumulative for each month. So just adding them all up, adding the new families for that month. And then these notes on how things are going, that more conversational, descriptive part is the part that we're really hoping you come prepared to share with us in those monthly TA calls. And that's when we'll be having some structured agenda items. We'll hit a rhythm with those monthly TA calls about the kinds of things we're going to be kind of tagging in with you all about, and then hearing about how things are going. And I'm seeing a note in the chat from Dawn, but will we need consent from clients notifying that they are involved in a pilot program?
No, I would say there's a key distinction here. This is not a research study. So that's why we're not talking about limiting it to specific clients and only those clients. We're much more open. This is what's considered a programmatic implementation kind of evaluation. So it does not require the consent in that way because it is part of your normal services. you're not going to be sharing with us any identifiable information about the families and the beneficiaries themselves. We've been very mindful to make sure that that doesn't happen. So because of the type of data collection and what it's being used for, it doesn't require the consents.
And the consent to participate in MIHP does cover consent to participate in any type of intervention implementation.
Yes, Julie, when you indicate that we have monthly data reports, which families were screened, do you want to know how many families or the names of the families?
Yep, not names. So just we're going to be asking for a total number. How many families did you screen to date? And then we'll talk about that in just a minute on the next slide. So we'll be giving you a link, not right now because we're trying to not overwhelm you all at once, but we'll talk about that starting in January with the monthly TA calls. We'll be giving a link and there'll be just some simple totals that we're going to be getting from you all just to understand how many families have come through. Okay, any other questions about this before I move on? Okay, great questions. Thank you all for being so thoughtful already. So as far as sort of some of those tracking processes, we have a couple options for how you can do that, knowing that this ACEs plan of care isn't, we're piloting everything, so there's no sort of official tracking procedures yet that you have in-house. So we have a couple paper-based options for you. Again, at the bottom of the decision guide, there's simply some notes sections so that you can, if you are more of a paper-based site, you can be keeping some notes around those pieces of like status changes that we talked about, or notes around how implementation is going. Joni also offered that in the actual progress notes section. Joni, I don't know if you'd like to talk about this piece, that there could be a place in that other visit information.
And typically with all of our plans of care too, there is a domain section on the progress note where you would document which interventions you do, and then also the beneficiary's reaction to those interventions. And because it is a pilot, we want to offer utilizing other visit information to actually record that at this point in time. We went back and forth of, do we create a new progress note for this and have you just use that? But the going back and forth between the current progress note and one that had the PACE plan of care too was really deemed to be more bothersome than helpful. So you can utilize one of these two options if you do have paper charts on the actual, decision guide, or utilizing other visit information. And that's more for you to be able to go back in before our monthly TA calls and see if there's anything significant that you want to share. Again, this will not be subject to certification review.
Okay, thank you.
Questions? Okay.
All right. And then we have a couple of electronic options too. The first one is the folks here at MPHI, we did create an Excel site level tracker for utilization. We have not shared this out with you yet, so don't panic. No one's seen it yet. We will share it out with you after this training, and it is completely optional. It is just another tool that if your site if you think it would be helpful to be tracking across different home visitors, for example, and it sort of is, again, a spreadsheet version of the decision guide, and it has some formulas in there that kind of does the auto scores for you, and it has places to kind of note if the plan of care has been delivered, and then some notes there. So if you are a fan of this type of documentation and that this would work for your site and your team, that is a tool that we've created, and we will be sharing it with you. But yet again, to emphasize, MPHI will not be seeing the Excel tracker, you would use that internally to track your families if that is a convenient and useful thing for you. And when it comes time for those data reports, you can use it to help you summarize the total numbers of folks who have who you've screened and who you have seen with the plan of care too. But we never ever would want to see this filled out Excel form. This would be for your tracking purposes only.
And then folks can use something else if they have an internal tool that they'd like to use to track. As long as we've got, a way for you to collect the information that you'll be sharing in those TA calls as we move along. And perhaps 6 months into this or 5 months into this, we'll have some ideas about another tool that might be more effective or easier to use as we try things out.
Okay. Any questions, concerns, thoughts about some electronic options for keeping track of the ACEs plan of care implementation?
Yes, I do see the question, Dawn, around the low level folks. We really are looking at the moderate to high as the primary folks that you'd use this with, but you may have some folks, because we are a program that serves all Medicaid recipients, as a standard, our families are dealing with low income concerns. So if you do have low folks that you want to utilize this with, you may.
And that also, that low is just built in. So you might be start the screener, the decision guide with families who end up coming in at that low level and then decide not to utilize the ACEs plan of care too. That's part of that decision process. So the fact that you screened them could come into this tracker and you would keep track of that, but you may have screened them and then they came in at low ACEs risk. Does that make sense too? Okay. I'll assume it does until I get, okay. Do we need to be tracking the intervention numbers we are addressing to in the notes we are keeping? You mean in terms of total intervention numbers?
We ask folks to actually track which interventions they use with families. So at this point in time, that's really not been a part of the discussion, and it may be something we want to do if we start to see trends of which ones are used more often. But at this point in time, it's really, who are you using this plan of care for? And is it a value with those families?
And I would offer that that's the kind of detail that we'd love to hear more about in those monthly TA calls. If there are particular interventions within the plan of care that you tend to be utilizing more with families and for what reasons or what has made you make those decisions, that's the kind of feedback we'd love. It's not part of the monthly quantitative data reporting, but we would love to hear about that. Okay. So many allusions to the monthly TA calls. They're going to be very rich, I think, we hope. So in those monthly TA calls, we'll have sort of we imagine we'll start with sort of a standing structure around questions about implementation itself, around those decision guides, around the conversations with families, around the interventions that you're using. We'll talk about successes and challenges each month. We'll talk about if you all have any specific technical assistance requests for our team, things that keep coming up or that we're all brainstorming as a group to figure out how to move forward. And are there any adaptations that might be required either right now in the pilot because of certain challenges that are insurmountable across every site, or that we need to kind of flag for an adjustment before the statewide rollout? Same basic thing with the monthly data submissions. We'll be checking in about successes and challenges with tracking the number of families screened and the number of families receiving interventions. Any TA requests you have for us around getting your data to us, we really want it to make it as easy as possible for you to do that. And again, any adaptations that need to be required for that monthly data submission. and then a place for anything new that's coming up that we haven't sort of covered. We figured this will be kind of the standing basic agenda. Our team will be listening very hard and taking a lot of observational notes so that we can be capturing what our process looks and feels like. So to figure out what we need to learn and to inform MIHP as they head into a larger rollout moving forward, the kinds of training, support, and suggested rollout that we discover here. Brenda, Joni, anything to add about those monthly TA calls?
Nothing from me. I'm just looking forward to hearing how it works.
Mm-hmm.
And Dawn asked a question about whether or not there needed to be interventions that were identified if you're utilizing the other visit information section on the progress note to document things. And you don't have to. If you find that helpful, go for it. You know, part of why we're not, again, including it in the domain section is we're really trying to get that higher level upper feedback first, and then we're going to drill down to what types of things might need to be changed or adapted.
And I think there was one other question in the chat from Kay Baker. Julie, if you can see that, it's about changing the level.
Let's see, thank you. Did we address that? I could see. Yes, so I think we talked about this a little bit, but yes, levels can change. We have a place on the Excel tracker to note like a status change as you learn more about a family, and you can also be keeping track of, on the paper versions as well as you get to know the family. And when we are creating our cumulative data reports, again, we won't get to that level of detail, but we do have a spot if you do have that data readily available. We do ask like how many families experienced a status change so far to date. And so that's, again, we hope to collect that in the monthly TA calls as well. But we are curious how much of your experience is that you screen once and a family stays pretty stable in that risk category, or if it really is a learning process along with the family and that their recommendation level really shifts over time. Let's see, there's another question in the chat. If the beneficiary is a maternal, we use the maternal plan of care too. And if the beneficiary is an infant, we're using the infant plan of care too.
Yes, and the reason we chose to, it's the same plan of care for both. And we had thought about just utilizing it as one, but because we have infant charts and maternal charts, we didn't want to confuse staff with not having that name the same way the other plans of care are. But they are exactly the same plan of care for both, just a different title depending on which beneficiary you're serving.
Okay,
Earlier, there had been a comment that if there's more than one plan of care, and then we're introducing the ACEs plan of care, to consider using that in lieu of the other plans of care. Should we be documenting, or did I not understand that correctly?
Yeah, not in lieu of, in addition to.
In addition to, so if we are.
Those other plans of care may inform your process in actually choosing the ACEs plan of care, but you still need to utilize the plans of care that score out or that are identified by professional judgment.
So if we're using, let's say we're using a substance misuse plan of care and maybe we're not seeing any progress with those interventions, and we do have the ACEs plan of care, and so we start utilizing those interventions maybe specifically around some of the substance use, should we be not documenting that, Joni, that, you know, during that visit, instead of maybe addressing the substance misuse plan of care, we chose to use the ACEs plan of care? We don't need to go into that.
You don't go into that level of detail, but definitely if you don't address the substance misuse plan of care at all during that period of time, you'll want to put that on the contact log at closure and say something to the effect of substance misuse plan of care was not utilized. ACEs plan of care was utilized instead, you know, and I'll talk with the certification folks about that and with Cherie, but you know, the intention is not to have this replace other plans of care, but to actually augment them.
Okay.
I think the way I referenced it earlier was in framing. So in framing to the family, it's a different approach when you're approaching about, okay, I want to talk to you about your substance use. It's different when you reframe it in, oh, okay, this is a piece that can impact your child. So like you said, if you're not having progress with the one approach, it might be good to switch it up and try the other one. So they're supposed to augment and help one another.
So I'm just thinking, Joni, of our blended, for example, the beneficiary is the baby, and then mama has another pregnancy, so we enroll mother, but we continue billing another baby. Would there be a situation where we would utilize both maternal and infant?
There could be.
Maybe I'm overthinking that.
Yeah,
but-
there could be, but you're going to use the one for the build.
Yeah, okay.
So if it's an infant, you're going to use the infant one. You know, and maybe we go back to having it all be one. Maybe it is too much to use for, you know, a maternal and an infant, but we tried to keep it as consistent as possible with the current plans of care.
So if we are, sorry about making this, so if we are billing on the infant and then we are addressing mother under other visit, because you're saying that we could implement mother's plan of care, just indicating that under the other visit on that infant's chart.
Yeah, I would use the infant plan of care and an infant chart.
Gotcha. Okay, gotcha.
And a maternal
Okay.
and a maternal chart.
Okay, thank you.
No problem. But if things become complex, we don't want this to be complex. We really want to reduce those barriers for use. And if you run across barriers or it becomes too much to think about, where do I do this and that, then that's important for us to know.
Okay. So we've already talked a little bit about this. This is just an overview of the data that we'll be asking you all for on a monthly basis. Again, all data reports will be cumulative, and we'll just ask for totals since the beginning of the pilot. So you don't necessarily have to kind of keep things tracked by, oh, did I do this in March or April? We just want kind of to date at the moment of data reporting, what are your total cumulatives? So again, we'll ask about that ACEs screening, and we will ask for number of families who fall into the different risk categories. And then we'll ask about the number of total families who've received any interventions from the ACEs prevention plan of care too. As an optional, if this is easy data for you to have and you can share it with us, we would be curious about how many interventions have gone out to the families at different levels of risk, but that really is an optional piece because we understand that's like an additional breakdown for your tracking that we don't want to make anyone pull their hair out too badly. So we're really, the big pieces are the risk levels for families after screening, and the number of total families who've received any intervention from this plan of care. And we will be sharing with you the links and kind of a how-to guide for how to report those data to us in January at a later date. This is just the overview of what to expect. And we are running close to the end of our time. We would love to get your feedback about this today's training. So many levels of training and feedback today. And so if I could actually ask you all to take a moment and at least pull up the training evaluation using either this QR code with your, if you have a smartphone, you can use your camera function to pull up the link, or a short link is there. And Brenda, I'm wondering if I could ask you to pop the link in the chat as well, if that's easier for folks to copy and paste over. We would love to hear your feedback about today's training and orientation again, so we can learn moving forward as more sites are doing this, which aspects of this training and orientation were helpful, and for us right now, what more are you curious, have questions about that we need to put on our to-do list to support you all moving forward come the new year. We are asking for your name on this evaluation as proof of attendance, and we know that some of your colleagues will be watching a recording of this, so that we don't know everyone who will be accessing it, but please know that your names will not be included on any evaluation data that's shared out with anybody. We're really just keeping track of who's watching the training. Thanks so much, Brenda. The link is in the chat as well. Oh, and Ryan, great question about when should you start? I know we talked about this. There's Joni, you have a great response to this. So.
Well, and I think anytime after January 1 is perfect. You know, our January meeting's really going to be looking at, and what date is that, Julie? Oops, you're on
January
mute.
25th, it's here at the bottom of the slide. Yep, at 11
Okay,
a.m.
that one will be really focused in on, you know, that startup process and any kind of challenges that we've had along the way. But yes, if you could start utilizing these after the holiday, that would be phenomenal. And if you can't, letting us know why is going to be really important. So that January meeting is really going to be a recap of everything that we've talked about, and then also how that startup has gone. And I am very aware of our time and that folks have 1 o'clock. So I don't know if there's anything else that we want to share before we conclude.
Nope, we will be sending a recording of this out with any additional and updated materials, and we want to encourage you to share that with your colleagues and anyone else who will be doing this moving forward. And hopefully you all have our contact information from all the emails that we've sent out, but we just so appreciate your time with us today. And please don't be shy about, as you're thinking about things, just let us know as other questions are coming up that we can address.
And I just want to thank everyone again for being willing to do this. This is really important work that we're doing. Again, in a time when we've got a lot of other stuff going on in MIHP. So we're just very grateful that you're willing and able to join us in this journey. All right. Anything else for the good of the group before we conclude?
I was going to ask her about.
All right. Well, I also have a 1 o'clock that I will hop off for. So everyone have a good afternoon. And again, please, you know, send us any questions that come to mind as we move along.
Thank you.
Thank you, and take care, everyone.
Bye-bye.